Uh, Good evening, everyone, and welcome to this What's All This Biomechanics stuff about. My name is Justin Blake. I'm a podiatrist based in Ireland. We're just going to give a couple of minutes for some people to come on to the feed, and if you have any questions for me this evening about anything that we talk about, I want to get in touch with me afterwards, then you can do that through the normal usual channels, especially on our friends on LinkedIn this evening. And so it's normally a little bit odd because I'm normally talking with somebody else on this. Hi, Linda. How are you? So we'll just give people a couple of minutes. Hopefully everybody's getting ready for the Christmas break and holidays. It comes around very quickly, doesn't it? Absolutely flies by. Of course, it's been quite a strange year, but we'll get to that. It's a talk for another day. So where do we start? Let me see. Let me just check this is on all the channels. Any questions, Linda? Whereabouts are you based? Okay. Again, so my name is Justin Blake. I'm a podiatrist based in Ireland. I trained in London at the aptly named London Foot Hospital all the way back in the class of 1992. I qualified from there. It was part of University College London, and it was great training. Absolutely fantastic, great grounding in podiatry and foot biomechanics. Then I was lucky enough to work in London all through the 90s up until 2002, when I worked with a great number of sort of practitioners, and it was quite into the sort of heyday of, or what to say, the golden age of foot biomechanics. Obviously, we were taught, like a number of people, all on the Californian School of Podiatric Biomechanics, all root-based theory back from the mid-1960s. But then, as I qualified, Kevin Kirby's rotational equilibrium theories and the methods of assessment came out in '87 and '89, and then Howard Dannenberg's seminal papers, Gait Style as an etiology, parts 1 and 2 is 1993, and those papers were sort of completely changed the way, especially Howard Dannenberg's sagittal plane facilitation theory of looking at the way that the foot functions. So to get away from sort of rear foot and forefoot inversion and eversion, and look at the foot in a more sort of sagittal, the more sagittal plane, and that sort of helped to sort of change and sort of progress biomechanics. But of course, then went on to sort of the tissue stress theories, and then the unified theories by Bevan and Harradine, which sort of tied everything together. So it's a little bit of mix and match. It's never been an exact science. Biomechanics has always been a little bit art and a little bit science as well, and the research sort of tends to help to sort of validate quite a while after what we're doing. But how that applies to normal the patients that we want to see day to day in our practices, and obviously a majority of our American colleagues we're probably more interested in the foot surgery aspect of treating foot problems. I was always a musculoskeletal podiatrist, and within London was lucky enough then to be able to work through the 90s with lots of different sort of physical therapists, orthopedic surgeons, rehabilitation therapists. Was able to, one story was when I first started working in private practice, and I had a patient with a medial meniscal knee problem. I brought him in to see the physiotherapist next door to help to hand over for the knee problem, because I wouldn't have been treating knees then, a couple of years qualified. And physiotherapist Neve's lovely girl wanted to know what tests I had done. And what assessments I'd done for her, well, I hadn't a clue. I hadn't done any. I just knew he was sore in the medial side of his knee, thought it was a meniscus. We hadn't really covered that in any of our sort of training. And you know, the biomechanics sort of journey began because it was always I always wanted to sort of continue to help to improve how I help patients. And so with the physical therapists and osteopaths and chiropractors and orthopedic and rehab therapists, I was lucky enough to be able to work, you know, with a lot of runners, a lot of dancers, you know, quite a broad spectrum, and especially working in London, it's quite a sort of young population as well. A lot of sort of triathletes, marathon runners, you know, a lot of weekend warrior, rugby, soccer players. So I got a great amount of experience, and then went sort of quite niche into certain areas. And you can look back and see one of my previous recordings with my good colleague Bernard Chesneau. I met Bernard and I saw how he had applied mechanics or skiing mechanics to body biomechanics and integrated that. And I went off and trained with Bernard and spent some time in France with him, and helped him to understand foot more and how he could integrate the foot more, and worked with a lot of skiers in terms of ski alignment. I was lucky to work in central London in a physio rehab centre where we looked after a lot of sort of skiers with and making footbeds and then integrating the footbed and the orthotic and the boot in with the alignment of the skier. There as well, we saw a lot of international athletes, a lot of runners, water ski jumpers, making footbeds for a water ski jumper to help with to control the inversion and eversion in the foot. So all sorts of very sort of specialist stuff. Great grounding. Did a lot of sort of bike fit and mechanics as well. And but the rehabilitation side of things was always something that was never really covered in basic podiatry. That was always left to the physical and physiotherapists. And so it was especially that around that time as well was the start of when people started to realize that you could integrate foot with knee and hip and change core and glutes and have you know a better sort of postural sort of position. And of course now a lot more patients are very much more sort of active and sort of with Pilates and yoga and strengthening and core. So a lot of rehabilitation exercises were integrated into the treatment programs that we used, and it was tend to be mainly sort of orthotic and foot insole based, shoe modification based, stretching and strengthening, and a lot of rehabilitation exercises, as well as the hands-on treatment that they would have had supplemented for the tissue with the patients. And that was the first time I was introduced to sort of rehabilitation programs. You know, you had to sort of progress the protocol and progress the patient through to sort of tolerance and sort of and sticking return to play protocols. So that was a great way to work, because you learn an awful lot more. I mean, I can assess knees, I can assess hips, but only because I work with great physios and great orthopedists who were happy to sort of share their knowledge. And so we want to sort of try and sort of simplify the biomechanics. And just to sort of quickly summarize, then when I returned to Ireland, then one of the keys to how I sort of try to simplify or understand myself how the foot function worked came down to a lot of training in manual sort of therapies and using foot mobilization and manipulation techniques to sort of alter the foot. And we'll quickly have a look at some basic biomechanics first in the foot, and then I'll have a look at a couple of x-rays that we would sort of look to see and check a couple of those papers and how that relates into how things work. So back to the foot. We're all sort of pretty familiar with it. I said inversion, eversion for root biomechanics, but Kevin Kerber or Howard Dannenberg was all sagittal plane biomechanics. And If you think of the three rockers in the foot, we've got the first rocker here, where the calcaneus hits the ground, and we're going to rock through here. And then as the foot plants on the ground, we've got the rocker of the talus here, and that allows the rest of the body, the tibia and fibula, which is connected to that, to pivot over the top of the talar head. So you've got the rocker 1, which is here on the calcaneus, and rocker 2 here in the talus, and then you've got the third rocker here through the hallux, and that's all the sagittal plane movement. And you can see on X-ray, and when we used to, our protocol for our foot mobilization patients was always a sort of before and after X-ray, and you can see sort of certain shunts and shifts in the position of the joints within the foot on X-ray. The more pronated the foot is, the more the talus angles to the medial side of the foot, and the more supinated it is, the more the talus angles to the lateral side of the foot. We're all quite familiar. If you know anything about feet or mechanics, say as the foot rolls and pronates in, the talus will move to the inside, and also then as the foot pronates, the talus will then drop down as well. And I'll show you just an X-ray of this. So we can see what I'm talking about, and this is quite an extreme picture. Application window. This is a picture. This is Christy. Christy was a very nice fella who came to see me. And this is the lateral view of Christie's foot, and here we can see the talus in the ankle joint, and this is quite a sort of a flat foot. And if we have a little look at the angles here that Christie's talus makes, you can see that I would expect that the normal sort of neck, let me get rid of this, the normal neck of the head and the head of the talus. Let me just clear this out. Right, here, let me just get a lateral view of Christie's foot again. Go to the other foot. Oops, get rid of these angle makers. Oh my goodness. Was able to use this before. Stop using the drawers. This is it. If we look at the angle of the talus here, I would expect that here the neck of the talus you can measure across, and then I would look to see that you would normally expect to see an angle where the talar head is in line with the first metatarsal head, but then you can see here that this is going to be dropped down at sort of quite an angle. So this is not very accurate, but a rudimentary measurement here would give a sort of a talar position of is dropped down here about 12 or more degrees. Now you want to be measuring that an awful lot more accurately. This ties in with where are the papers? Some of the hard Dannenberg papers. The gait style and etiology and postural conditions. And Dannenberg sort of shows this type of foot, this type of extreme rocker bottom foot, the pes planus type of foot that we would expect to see in a very, very sort of pronated, very, very pronated foot, where you get this sort of like mid-foot sort of break. So here we can see this in Christie's foot here. We just zoom out a little bit more, how flat that sort of foot is onto the ground. And then if we look at the foot on the AP view, again, my goodness, get rid of this drawings. Again, here you can see that the talus is sort of medial to the foot, and there's a lot of sort of midfoot compression there and a midfoot osteoarthritis sort of happening. And we look at these laterally again and zoom this up. Again, this is back to the opposite foot. Huge amount of talar inclination angle, probably even more than on the opposite foot. We can see how the talus is shunted forward in the ankle joint, and then as that's shunted forward, it's had a knock-on effect into the mid-tarsal joint. And so what I sort of see in practice is that when you get a shunt forward of the talus shunts forward, it has a knock-on effect into the navicular and into the cuneiforms, and then on into the metatarsals. And you can take it sort of very simply that obviously the foot has a medial and a lateral column. The medial column made up of the talus and the navicular, and the medial cuneiforms in the first three metatarsals here, and the lateral calcaneus and cuboid. And so where you get this sort of medial column and lateral column, if you get the talus pushing forward with a more pronated foot in the triplanar movement, it shifts down, as we saw on Christie's foot. So the talar inclination angle should have sat here, and his was what, 10 or 11 degrees down like this way. So the foot was doing this. As the talus has moved forward, we saw all that compression in the mid-tarsal joint. Depending on the theoretical axes, those ones, depends whether you get a hallux limitus or a hallux rigidus, or a hallux valgus. So as the foot shunts forward, the talar position shunts forward, and it pushes into the midfoot and then pushes into the hallux. Depending on where the axis is, you'll either get a sort of a driving of the first metatarsal into the hallux, and that will give you your hallux limitus and hallux rigidus over time, or else you will have a slightly different deviation in the axis, where you'll end up with a bunion, where you will have hallux valgus, where the metatarsal will push out this way and the hallux will come across. And those are the sort of two sort of very familiar variations that we're used to seeing with foot: bunions, hallux valgus, or hallux limitus leading on to sort of hallux rigidus. And somebody like Christie's foot, again, that extreme case, it always struck me as very sort of strange about why he got to 65, nearly 70, 68 years of age before he started to develop a lot of ankle and mid-tarsal joint pain. And again, different people have a different envelope of being able to cope with the tissue, being able to cope and adapt to the stresses and strains on there. Again, if we go back to that X-ray, this is not something that has happened over time. This is something which has happened over a number of years, as the talus has shunted forward in the ankle joint and moved down here and compressed through here. I mean, this is his navicular here, and there's not very much left of it. It's very sort of very sort of compressed through there. But I say Christie's is quite the extreme. Christie is quite the extreme example. If we have a look at us, just one other X-ray, then we don't get as an extreme of the foot function there, but we can sort of see similarities. Again, lateral view of the foot. If we look at the AP view of the foot, just swing the image around. Again, what I would look to do would be to look at the angle that the talus makes with the midline of the foot here. So again, you can bisect here quite accurately. If you've got more time, you bisect across the midline of the neck of the talus, and they look at the position of the first metatarsal to the midline of the foot, and you can compare that to either side, and that should be within certain limits. And then you look at the lateral side of the foot again, and then as with Christie's foot, you want to you're going to look at the talus angle here, and you can see that sort of talus is sitting more sort of level there compared to sort of to Christie's. So there's a general sort of shift and change of the position of the foot structure over time, and that depends on the position of the talus, how much pronation there is, and all the different sort of angles. I have goodness gracious, what sort of sport sheet would you be looking at? Well, thanks, Ina. Christy would have been the type of patient that I would have struggled with a couple of years out of college. You know, that really flat pronated pes planus type foot, you know, pancake. What are you going to do with that? You're going to try and control it. If you go sort of pure sort of biomechanics and Kirby, I mean, he's got an axis on his medial side of his foot, which is somewhere over here. It isn't within his foot anymore. And of course, you got to remember that back to your Kirby sort of papers, on the medial muscles on the inside, your tib post and your functional hallucis longus, they're all acting to pronate the foot more. So with that type of foot, I would really struggle with an orthotic type of shoe, or orthotic, and then a shoe to help to support that. Christy responded very, very well to just a very simple manual therapy and some mobility exercises and some strengthening for his foot structure. And yeah, again, you know, even though he said he had he'd only had about sort of 6 months of problems, when you looked at the x-rays, they're absolutely sort of shocking. The foot's completely destroyed, but he just needed a bit of mobility, a little bit of flex, and you know, the foot's, you can make it very complicated. The joints are a little bit stuck and stiff. It just needs to get bending and moving a little bit more. It can get more and more compromised and stiffed, and the foot sort of function. And when you get somebody in 50, 60, 70 years of age, you know, there's a lot of sort of happen. It's a glacial sort of progress over time. So you don't need to completely reinvent the whole and improve the foot structure like it was never, you know, back to 30 years ago. You just need to improve it slightly, and that sort of falls in with sort of tissue stress theory. You know, you just don't need to unload a tendon completely. You don't need to unload the forces within a bone, so that you'll get more osteoblast action to allow sort of repair and healing. You just need to reduce the stress and the strain just slightly below the threshold where it can start to heal. So a lot, like in a lot of any tendon rehabilitation and muscle rehabilitation, it's got to be below the sort of threshold. So we don't need to optimally correct the mechanics. We just need to improve the function very slightly. And we had great success doing that with a lot more sort of manual therapy, whether you do that yourself or you integrate that with a physical therapist into your practice to be able to do that. Because it always struck me as strange. We work with both, Ina. I would have worked with osteopaths and chiropractors who would have done a lot of manual therapies before, but in the last number of years we specialized in more manual therapies, yes, as another sort of treatment option for patients. Especially with the patients who have come with a bag of 3 or 4 orthotics that have been to see other people and they haven't worked in such a way, however it's supposed to work. Those patients who are not sort of quite surgical candidates can give them a lot of sort of comfort and relief before they need to go on to sort of surgery. And you can also use a lot of these things as well as sort of prehab, sort of pre-surgery as well. But yeah, we would have had manual therapy, hands-on treatment programs for patients to go through with home exercise and strengthening to improve the foot function. Just as I did, and just let me see, Lisa says, down. other than a first metatarsal cutout. Yes, again, I don't know whether, Lisa, whether you've sort of taken the actual joint itself and give it a little bit of a stretch and give it a little bit of a move and just get it sort of moving more. I know, find that, you know, people crack and release knuckles. Again, it's if the foot is compromised and the foot function, and you got to look at it like a very sort of intricate sort of like gearbox. And you know, if you're driving your car today, and I suppose all you guys aren't driving stick shifts but automatics, but you know, it's something's not, if the cogs aren't meshing right, or like a watch mechanism or on a door frame, if things aren't meshing right and the alignment isn't right, we're going to get wear over time in the joints and uneven pressure through the joints, and that's going to cause joint degeneration over time. And that's where you're going to sort of see that sort of a lot of that compression through the midfoot sort of happening, and the deviation of the joints. And so, and also then, and we work with a lot more, because we wanted to avoid, we built our practices around, we could actually help to improve your foot and leg pain without having orthotics, without having surgery, and without having taking tablets or medication, or just having to put up with things. So using the manual therapies was quite a good way of setting ourselves apart from the other clinics, because everybody's doing orthotics, everybody's doing surgery, everybody's doing injections, but nobody's giving us sort of alternatives sort of to that, to the symptom relief type of injecting PRP or steroids, or just a surgical option. So and of course, patients now are researching an awful lot more. I'm sure you've all had the patient in who's had the diagnosis already with them. They can tell you exactly what's wrong with them. I don't understand why they need us. But so foot function is quite simple. It's very complicated, but you can make it sort of quite simple. The talus is the key to everything. The talus being the astrogalus, the center of the universe, and the talus is quite special. Of course, it's only one of two bones in the body, doesn't have any muscular attachments. It controls the whole function of the subtalar joint, the foot and ankle joint complex, and a lot of problems come from the talus. All foot problems are biomechanical, of course, in origin. Unless you stand on something or drop something on your foot, or if you fall over off a curb, that is everything else is going to be biomechanical, whether it's underlying biomechanical alignment or congruency of joints, which dictate the function, or whether it's the mechanics, the external mechanics has had an action on you. And everybody's quite familiar with a normal sort of ankle sprain, lateral ankle sprain, where you just flip over on the ankle and continue on, give it a rub for a few days. Everybody's had one, quite innocuous. And left untreated, that is can give quite a sort of long-term detrimental sort of effects. And you can see that you'll be able to see that anterior shift of the talus within the ankle joint. That stops a lot of ankle joint dorsiflexion. We can get on to talking about ankle equinus. So yeah, again, ankle, if you don't have dorsiflexion in your ankle, you have ankle equinus. If you sprain your ankle and you anteriorly shift, which is what happens, the talus will anteriorly shift, and that will block ankle joint dorsiflexion as well. And again, you'll have that knock-on effect then through into the foot. And as that gradually sort of progresses approximately distally, you'll have the whole sort of shunting on and things. I mean, orthotics, like them, they work, but I'm not too sure how they work. And there's supposed to be load modifiers now. I'm not too sure whether they do any cutout. And then Lisa, if you're still listening, in terms of your functional hallux limitus cutout, How can something putting a cutout underneath here, and obviously it will allow the joint to drop down, allow the hallux to dorsiflex more. Okay, but if the reason that you've got your hallux limitus is because your talus is anteriorly shifted and it's pushing through here and pushing through there and jamming that up, well, you can allow more function there, but if we don't actually get this talus back into the ankle joint and get that mid-tarsal joint more flexible and stopping it compressing, because as the talus moves forward, where are we going to go? As the talus moves forward, it'll push up this the metatarsal into the hard to see it. We'll push it further more, and that will cause more compression of this joint. You'll end up losing the gap in the joint as the hallux, or as the metatarsal pushes into the hallux, and that will cause it restriction. So there's a bend in the toe, and if I push this metatarsal forward, there's no bend in the toe. So how will it cut out underneath here affect it? It'll help them function a little bit, but the real cause is the talus moving, pushing forward. And with manual therapies, you can actually sort of see before and after over a period of time. You can actually see a change in the position, an improvement away from the compressed joint sort of positions. And there are sort of a couple of papers. One with my colleague who I did the training in with is Ted Jednak. There's a paper there of case studies, pre and post foot mobilization therapy programs, and change in intermetatarsal and decrease in intermetatarsal angles. There's one of my colleagues, David Cashley, is just about to produce a paper for manual therapy. He's had very good success with manual hands-on therapy with neuromas. Great fan of this. It was said it was just one at the course in London when we did it. It was like, okay, well, how come nobody explained that before? Because this is why orthotics don't work for rocker bottom feet. How can you try and change back something that's taken 30, 40, 50 years to develop with a fancy bit of carbon fiber or EVA and mold it to try to push it somewhere else? And even though orthotics aren't arch supports, especially with that rocker bottom foot, you're trying to force the foot. It doesn't work like that. You're not going to sort of change that by just pushing something in. The patient just won't be able to tolerate it. And the manual therapies were just a really good way of restoring a lot of foot function, strength, and mobility. Before then, you had to do an awful lot less intervention then with orthotics, with footwear modifications, and with interventional therapies then further on. Improve function, improve strength and flexibility, and get rid of stress and strain, and keep people active and mobile. That's what people really want. And I say but a lot of things. Where are we going to go with this now? Mobilizing works really well, but again, it's everything. You want to use everything, and the journey still continues. I mean, that's why we've done a lot more work now with more integrated body mechanics now, looking at how the hip and the pelvis will rotate and move, and how that works with. And again, we've integrated with other practitioners. We can improve the foot function. They can improve the rest of the body function to help with the mechanics. It's hard to know where to sort of take it now. We're not getting getting sort of feedback with questions. So that's it. Simple biomechanics, root-based theory. A long time ago. Bob Kidd, my anatomist colleague, who we did an interview with, and again, a lot of my interviews that I've seen with a lot of the people that I've worked with over the years, all available on LinkedIn, on my YouTube channel, if you can't see them. And some very interesting chats, especially with Bob Kidd, the anatomist, who looked at all the archaeological changes in the bone sort of position in the talus compared to us and our ancestors over time, and how that mechanics has sort of moved on. And So taking the mechanics that based on in terms of Dannenberg, the sagittal plane and Kirby, and then looking at sort of tissue stress and combining that with a lot of rehabilitation and manual therapies to improve function. And and then working with more integrated body practitioners, anatomy and motion practitioners, to integrate that then with the patient. So it's everything is still learning. We're actually running a course on with this covering these topics in January, and these will really be sort of suitable for experienced practitioners who are looking for new and innovative ways to grow their practice. If you're new to sort of biomechanics and want to sort of grow your sort of knowledge, and you don't know where to start, how are you going to kickstart your practice, and especially when you want to grow now your practice without having to rely on referrals from doctors, especially on our insurance companies, because other colleagues in the States know insurance companies don't want to pay, and doctors will want to refer in-house and keep it within network. So the courses that we do, the biomechanics, simple biomechanics courses, they integrate a lot of the way I'm looking at foot function and how to simplify improving the outcomes that you're going to getting. But we also want to integrate that into the practice as well, because a lot of the things that I always found was, and a lot of the research says, everybody goes off on a course, spends a couple of days, learns a new technique, and then never implements it in their practice. And how strange is that? I think it's less than 10% of people actually implement something new that they've learned in their practice as they go along. So, and that's where I always sort of struggled with new techniques, was how do you implement them, So I'm going to show you the exact systems that I used alongside the biomechanics I used within my practices to build a profitable podiatry practice. The strategies give you the results and bring ethically long-term great results to your patients. You want to understand the why between everything that you're sort of doing, and have step-by-step systems in place, so that you can monitor and progress and see the progression of your patients along that as well. Topics that we're going to cover in within the courses are, what's the patient really there for, and why do you want the outcome? Especially when everybody's had that patient who sits in front of them and tell me your story, and they go on to tell your story of their 5, 6, 10 years of ongoing struggles and problems and trying to have it resolved at certain things, and you're sitting there looking at them going, okay, this has been 5 years, how come this is taking so long? And it's never normally that the patient never really wanted to get it fixed, it's just they didn't know how to do it, or maybe went to see other therapists before, tried orthotics, maybe had surgery and never got the outcome that they wanted. But you really want to discover what the root cause of the problem is. And we're all back to when I was very young and naive with my physical therapy colleague in the next room. We're going to cover a lot of dynamic and functional assessments and tests that really matter. Because there's loads of tests and loads of assessments that you can do, but what's pertinent for that particular patient? We'll cover a lot of how you progress the patient from first treatment, then progress them through to back to return to play activity, or to what they're wanting to do, and go through a lot of sort of advanced sort of clinical reasoning and skills. Orthotics will be a huge part of, I think, a lot of most people's practices. So there'll be quite a lot of emphasis on casting orthotics and prescription writing for orthotics and variations. And also mainly, also using chair-side orthotics and strapping. Foot mobilization therapy will be covered. Assessment with knees, hips and backs, because you need to be able to integrate that in, especially sacroiliac and joint and hip and knee function. Leading on to foot function. Clinical tests, more advanced sort of MRI and scans that you'd want to do, more advanced clinical reasoning skills. These will all be covered in the course, which will start in the new year. All the details can be found over on my website. That's at justinblakemedia.com. I will share the screen with you again. Get this working. So here's the outline of the course here. You can see find out more information about me through here. Tells you about my sort of whole history, right through from qualifying the kids, my sailing, working Special Olympics. We've got quite a great podcast with everybody who have had on my journey over the last number of years. We've been sort of cataloguing the patients they want to see. So we've got a number of digital courses, website, and we had hoped to run practical courses in Spain and London this year, but of course that didn't, Spain, London and Dublin, but that didn't happen. So we're going to have to extend online. So details are at Justin Blake Media on the courses section, and you can find out more information there. You can DM me if you want any more information. And you also get a free report there as well if you sort of sign up. We've got one of these. We use these reports in a lot of our practices. These are really good, simple sort of reports. Free. Use them as an ebook. A little bit of information in them for the patient. A little bit about you, how you can help them in their practice. Use this as an ebook to either print out and send out to patients, use it in your practice, or especially use this as a lead magnet on your website, so somebody can sign up for that. So we have those as well onto the site. So thanks everybody for listening. Hopefully it was pretty coherent. It's a little bit difficult when there's nobody here to actually sort of get bounce ID back from or hear back from. Anybody has any questions, they can DM me afterwards. We'll run one of these early in the new year. We'll get a little bit of feedback from this and find out more people want. So thanks very much for listening. I hope you have a great Christmas, and we'll talk to you again soon. Thanks very much, Dave. Thanks for watching. Bye-bye.